Many years ago, I felt that if we're trying to improve quality of life by saving the eye and saving vision, we need to measure our success rate. We need to understand how our patients are feeling, whether they have the eye removed, whether they have radiotherapy, so that we could decide what to do, and so that we could warn patients about what they're likely to experience, so that when they do experience any side effects or anything like that, they know they're not alone, and they know that it's part of the plan. Not plan, but part of the journey. So I designed a questionnaire, and working together with our health psychologist and Nicola Longrig, one of our data managers in Liverpool, she every month she sent out questionnaires to all the patients who had been treated in that month of the year, after checking that they were still alive and checking with GP and checking the consent and so on. And so in this study, we're able to analyze the quality of life of about 1,500 patients. Treated patients coming from England or Wales. So all patients were invited to fill in this questionnaire 6 months after primary treatment, and then on the anniversary of their treatment. It would have been nice to complete questionnaires before treatment or the day after, but patients were very stressed at that time, and I didn't feel it was fair to ask patients to fill in a lengthy questionnaire when they were very busy getting x-rays and tests and blood tests and all the rest of it in time for surgery the next day, and when they were upset by diagnosis. So that's why we started 6 months. So we sent questionnaires out in self-addressed envelopes, and then Nicola computerized everything. With regards to treatment, first choice was plaque radiotherapy. If that wasn't likely to give a good result, we gave proton beam radiotherapy. If that wasn't likely to give a good result, then we did some sort of surgical excision. And if that wasn't possible, the eye was removed. So, just as you are hearing now, in Liverpool, where the study was done, we decided on treatment in a consensual manner, making sure that the patient understood. The nurses were extremely important, because no matter how much I ask you, do you have any questions, you'd say no, and then you'd go into the next room with the nurse, and you'd have 100 questions for the nurse that you could have asked me, but the nurse is much nicer and all the rest of it. So, but anyway, I know that you sense that it's a busy clinic, you don't want to take up the doctor's time, but that's why it's really, really invaluable to have a nurse available. I would just sort of say what I had to say, and then I knew that the nurse would take over and spend lots of time doing what you've just said. Communication aids, really important, printed information. And since 1991, every new patient I ever saw got an audio recording of what I told them. First on a cassette, then when those went out of fashion, on a CD, and then in San Francisco with an iPad, the talk got emailed to them. And now I'm trying to find a legal way to share audio recordings with patients that's ergonomic and doable. We can't just email using Gmail. Everything has to be very secure. So there's an organization, Patients Know Best, and we might do something with that. And then online information, copies of letters. And as you've just heard, emotional support is so important. From the nurse, we're fortunate to have a full-time health psychologist in Liverpool who saw every patient and almost every patient and was able to give them all the help they needed. And we also helped with financial expenses, and which mount up over the years. So the group consists of patients who've had radiotherapy and patients who've had enucleation. I left out the local excision patients because they're a smaller number. But the two groups are not comparable. Patients were more likely to have the eye removed if they were male, and if they were older, and if they had a more advanced disease, which reflected on their survival. And once we removed an eye, we didn't tend to bring the patients all the way back to Liverpool again, because they lived very far away, most of them, and we didn't feel they wanted to come back. So the follow-up was longer in patients with radiotherapy, because they had to keep coming back to see us to make sure the tumor was dead and so on. So the follow-up was longer with radiotherapy than with enucleation. Not all patients kept perfect vision after radiotherapy, as you well know. These are patients who lost vision of 6/12 or better. You can see that about a third of patients lost that vision after plaque treatment, and 2/3 lost that vision after proton beam treatment. Because the patients who had proton beam either had a bigger tumor or it was right next to the fovea, which is why we didn't put a plaque on. This is, I can't read my own writing there, local tumor control. Yeah, treatment failure was very rare, only about 3%. Because if I wasn't really confident that we're going to kill the tumor first time, the patients usually had the eye removed. And some patients, we stuck our neck out a bit, they were keen to try it against the odds. And so about 3 in 100 had the tumor come back, which is low. And after radiotherapy, some patients lost the eye, especially if they had proton beam because they had bigger tumors, toxic tumor, and all that. So one of the questionnaires we used was the EORTC Quality of Life questionnaire, which I helped design many, many years ago. And its focus is designed specifically for uveal melanoma. So one of the sections is on visual function. And I'm going to show you a number of these. And white means no symptoms, no problems. And black means that there are lots of problems. So the more black you see, the worse the symptom, the more severe the symptom. And on the right, you'll see these curves here. The black is after enucleation, and the continuous line, and the dashed line is after radiotherapy. And this shows the trend over time. So for instance, reading difficulty, there was no significant difference between patients who had the eye removed and patients who had radiotherapy, because nearly all patients had good vision on the other side. And there wasn't much change with time. There it is. So difficulty driving, there wasn't that much difference between the two, but that was with regards to difficulty driving, but that was because a whole lot of patients had stopped driving. And once they stopped driving, they didn't have any difficulty driving. Shows how careful you have to be to interpret these results. At night, driving at night, it improved over time after removal of the eye, because people got used to driving with vision in one eye. Whereas after radiotherapy, the exudation increased over the years, so it became more difficult over time. But again, so more problems driving at night. Difficulty pouring drinks. As soon as you have one eye removed, you immediately lose your depth perception. So, but over time, there was, practice makes perfect. Whereas with radiotherapy, it gets a bit worse. Same with walking on stairs and on cobbled street or paving when the tiles are different colors. It's difficult to... Am I resonating? Are you experiencing these things? You are not alone. So more problems there. Walking in crowds. So with these data, I'm able to tell patients, if you bump into someone in the street, just don't let it upset you. Just laugh at it. Or if you pour and you miss the cup, decide from now whether you get upset or not. You're still going to spill some milk from time to time. It's up to you whether you get upset or not. If you can not upset yourself, if you can laugh at it, you'll be happier than if you don't make that decision. So same walk in crowds, especially with men, because women expect men to stop and let them pass first, and they haven't been seen. Of course, it doesn't happen. So activities are more likely to be limited after enucleation than after radiotherapy, as you'd expect. And comfort. Much more discharge from the socket than after radiotherapy. More watering. Not much pain. After radiotherapy, headaches are a bit more common and severe after radiotherapy than after enucleation. And now come to worries. Worries about metastasis. As you can expect, patients are more worried after enucleation because they've been given a worse prognosis on the whole if they've had a bigger tumor. Not all patients have a big tumor, but they're more likely to have had a big tumor, as you've heard before. And at first you're very worried, and then you get used to the idea and you get less worried. And then something happens in older age or after a long time that some patients become a bit more worried again. Don't know why. There's a curve over the years. Worries about recurrence in the treated eye. As you can imagine, if you've still got an eye, you're more likely to be worried about tumor coming back in the eye. But what's surprising is that there's quite a few patients there who, after having an eye removed, are worried that the tumor is going to come back in the eye, and they don't have an eye for it to come back in. And it's sad. And I think it happens because once the patient's had a enucleation, we don't bring them back because we imagine that they don't want to keep traveling all the way to Liverpool or Sheffield or wherever. But patients are perhaps losing out because they forget the good news that they were given. And over the years, doubts arise in the mind. And so this taught me that we somehow need to reach the patients we're no longer seeing and reinforce any good news that they have. Worries about appearance. Whether the eye is removed or not, most patients don't seem to be too bothered about their appearance. 1.5, that's a low score. Look, there's not much black there. And so that's encouraging. And a lot of these patients had acrylic implants, not these very, very expensive hydroxyapatite implants. We did a randomized study in Liverpool comparing hydroxyapatite costing £400 a ball with acrylic, which costs about £40 a ball, and the results were not significantly different. Then there's anxiety and depression, using a standard questionnaire. As you can imagine, there's more anxiety as soon as you get your diagnosis, but things improve over time. But on the whole, it's not too bad for most patients. Depression increased after enucleation more than after radiotherapy, perhaps because they're older patients or men. I can't explain that. Then there's well-being. Got physical well-being, same in both groups, on the whole quite good. Emotional well-being, not as good. Doesn't change much over time, not much difference between the two. Social well-being, good. Not much difference between the two, no difference really. And functional well-being improves very slightly after radiotherapy and diminished slightly after enucleation. On the whole, very, very slight difference between the two treatments. This is important. This shows well-being in our patients in comparison with the general adult population. We didn't have data for the general British population. And because we're within the dotted lines, according to these data, the well-being of patients with ocular melanoma is not statistically worse than the general population, believe it or not. Same with the cancer population. There's a dip with regards to emotional well-being. These are the questions that test emotional well-being. Sad and nervous, worry about dying, worry that my condition will get worse. And I think it's those two questions that cause that dip. So here are the patients who had disomy 3 melanoma, and here are the patients who have monosomy 3. And surprisingly, the difference is sort of borderline. There's not that much of a difference. You're better placed to explain this than I am. I think that patients with monosomy 3 adjust to the prognosis and make the most of it. And I don't know, you know more than I do. Again, what's sad is that there's quite a few patients with disomy 3, excellent prognosis for survival, and they're still worried they're going to get metastasis. I have a feeling that part of it is that if we had a patient with monosomy 3, we used to give the patient a lengthy explanation and psychological support and emotional support and so on. Whereas if they had a good melanoma, disomy 3, we just send them a letter saying, congratulations, you've got a good melanoma, relax. And they didn't believe us. So it shows that we need to try harder to convince patients that we're not just being nice to them by giving them good news, we're being honest. Perhaps patients feel we're not being honest, we're just being nice. You know better than I do. I'm just imagining here. You know the answers better than I do. Hopefully you come up with. So fear of metastasis, there's a fear of metastasis, even disomy 3 patients. So when it comes to the self-reported quality of life, patients had to give themselves a score as to what the quality of life was. On the whole, it was pretty good, except for a small proportion where it was poor, and no difference between the two types of treatment. But then when we looked at these patients who had a poor quality of life, we asked them whether the poor quality of life was because of their eye or because of something else. In most patients, it was something else that was reducing their quality of life, not their ocular condition. Of course, there were patients whose quality of life was diminished by their ocular condition. But in most patients with poor quality of vision, it seems, according to the data, that something else was reducing their quality of life, your quality of life. So what is it? Well, quality of life depends very much on social support. Patients who live alone, who are widowed or widowed, bereaved, makes a big difference. Patients who are unemployed, perhaps have financial problems, unemployed because they're unwell or for whatever reason. Patients who are unwell for other reasons, arthritis, some other malignancy, some other disease. Treatment, no difference between the two kinds of treatment. So that's really, really important. There's no difference between two kinds of treatment when it comes to general well-being. So I would summarize this by saying that it's very important for us not just to think about the tumor and not just to think about the eye, but to think of you as a person, as a family, because there's so many influences. And that's when we used to have our MDTs, the psychologist used to come to our MDT in Liverpool. Hopefully she still does, although I'm not there anymore. And she used to have to give us an anecdote to educate us. She used to tell us about a patient she'd spoken to the previous week. And she used to tell us things we never imagined, how a patient's behaving a certain way because of some sort of problem in the family or something that happened in the past, something else. And it's not something you think about unless you're educated about it. So, despite having worse vision, despite having more discomfort, there's not much difference in the quality of life between patients who've had the eye removed and patients who have had the eye saved. So what that means, I would summarize this by saying better a good enucleation than a bad radiotherapy. So we can reassure patients that it's not the end of the world if you have your eye removed. You'll adjust, you'll be okay. It's much better to have an eye removed than to keep coming backwards and forwards to the hospital, having lots of treatment because of complications of radiotherapy, or scarring of the eyelid from the radiotherapy, or double vision, or something terrible like that, And most of these patients attributed their poor quality of life to things other than their ocular condition. Tell me if you agree with that or not. And there's a lot of adjustment that happens. And we need to understand this in order to be able to provide counseling, reassurance, and warnings about how they might feel and so on. And I think some of the factors that cause a poor quality of life may also contribute, in some patients, of course not in everybody, to enucleation. So it's not the enucleation causing poor quality of life, but the poor quality of life causing the enucleation, because you get patients who they neglect themselves, or they're not feeling happy, so they don't have the energy to see somebody. When they get blurred vision, they delay a long time in some patients. So it's important to understand these things. So in the second half of my talk, I'd like to report on a study that we performed in the United States with the Ocular Melanoma Foundation. They conducted a survey on the internet, and a whole lot of patients answered and completed the survey. And we recently published the results in a journal of ocular oncology. What's good about this is the patients came from all over the United States. They weren't exclusive to one center. Most of the patients were women, because perhaps they were more inclined to complete questionnaires than the men. And the distribution of tumors in the eye, back of the eye, front of the eye, was as you'd expect. So this is a satisfaction with tumor detection. And I'd like to emphasize yellow is good and red is bad. So most patients were satisfied. And although it's reassuring to hear about good patient satisfaction, we don't learn too much from that. I'm sure we can learn more than we do at the moment, but we can learn a lot from our mistakes and from what's not working well. So, and there's nothing better than an anecdote when you put things in the patient's own words. So it's really, really common for patients to see a doctor or an optometrist several times before the tumor is detected. I wrote a paper on 2,500 patients in Britain, and maybe about a quarter of them had their tumor missed at least once the first time they went. The next patient regrets that their optometrist never dilated their pupils. And I've spoken to optometrists who say, oh, their patients are in a hurry, they don't want to wait 10 minutes. Well, I'm sure patients do want to wait 10 minutes to dilate the pupils if they're given the chance. And another ophthalmologist is accused of never listening to the patient and attributed the blurring of vision to stress. But please remember, most of the pie diagrams is in yellow, so most patients are happy with the result. Perhaps they shouldn't have been happy with the results. They might have been badly treated without knowing it. But anyway, that's satisfaction with tumor diagnosis. So many patients are diagnosed as having a nevus, a mole, a benign mole, and then watched for several years. And then either they see a different doctor or symptoms of it, and then suddenly they hear it wasn't a mole after all, it was a melanoma all along. Like this patient who, after years of monitoring, was found to have a class 2 melanoma, which means a monosmer 3 melanoma with a terrible prognosis. And the patient really wishes that they had been involved in the decision making. They would have had a second opinion, perhaps. So why does this happen? It's perhaps practitioners practicing beyond their competence, either because they don't know the facts, they're not aware of the clinical features, or because they don't have the right equipment. By the time I see a patient, by the time a patient walks through my door into my clinic, I've already seen the color pictures, the OCT, the autofluorescence. I know the tumor inside out. In fact, I've got to be really careful not to forget to look at the back of the eye, because you expect the doctor to look at your eye if you've traveled a long way, and if he or she doesn't do so, you feel shortchanged. But I see more from the pictures than from looking at the back of the eye in some cases, because you get so much wonderful detail from the scans and from the images and so on. So perhaps there are practitioners, I expect there are practitioners who are just relying on a look without photography, without ultrasound, without OCT, without autofluorescence. And the question is, should they be doing that if they don't have the right equipment? And with some scope for improvement, this is it. And then lack of consent. We are very careful to document patient consent when we do things, but there's nothing in the books about documenting consent when we don't do things. We're allowed not to do something and not document, but that's wrong. It shouldn't be like that. So you get these patients who, some of you might have experienced this, have just been told it's a benign mole, don't worry, see you in a year. But the person should say that the reason why you're being seen in a year is because there's a chance that this is not a mole, it's a melanoma. And if patients are not told that, then they're not giving informed consent to their management. And then a few years down the line, they might have done things differently. They might have gone for a second opinion. They might have kept their appointments instead of just leaving it for another year, as often happens. Treatment. Well, most patients had a plaque, some had proton beam, and yellow are enucleations. There are some recurrences, some secondary enucleations, and patients were generally satisfied with the treatment they received. Treatment selection. One problem is that patients complain about is that they're only told about the treatments available at that hospital. They're not told that if they go down the road or into the next city, there's another treatment available that would be much more suitable for their particular tumor. So that's another example of lack of informed consent. So if we're going to try and improve things, we should try and improve the consent process across all centers. Prognostic biopsy. It's nice to see that most patients were told about prognostic biopsy in this group, but an awful lot weren't. Now we're on very, very thin ice here. Patients complaining because they weren't told about the possibility of a biopsy, or they were discouraged from having a biopsy, and so on. But the problem is excessive expectations. In some centers, we're lucky enough to be able to do biopsies on everybody because we've got a very skilled surgeon who can biopsy tumors less than 1 millimeter thick, because we've got a laboratory that can cope with tiny, tiny specimens, because we've got the funding to do the genetic tests. In other hospitals, the surgeon, the ophthalmologist, is desperate to do but they just can't. They just don't know how to do the biopsies. They don't see enough patients to get the skills. They don't have a friendly vitreoretinal surgeon who's got the time to do the biopsies. They don't have a laboratory. They don't have the funding. So if you're upset at not having a biopsy, I'm sure that there's an awful lot of ophthalmologists out there who are very upset at not being able to offer you a biopsy. And so you might think they're just being lazy, but they're not being lazy, many of them. They honestly want to do it, but and they're trying probably, they're trying to get funding, they're trying to entice a retinal surgeon to do biopsies, but they still haven't quite got there yet. Now, a lot of people, especially the ones who don't do biopsies or don't do genetic testing, say, oh, what's the point of doing genetic testing and giving a prognosis if there's nothing you can do about it? Well, first of all, according to a study we performed, uncertainty is more stressful than even a bad prognosis for most patients. Secondly, a prognosis, there was a comment earlier on, but one thing prognostication does is that it gives you time to prepare for any eventuality, so that you don't start looking after yourself when you've got symptoms and a few weeks left or a few months left. You've got a whole year in which to do your research, to get in touch with Ocular UK, to find out the best center for treating liver tumors, and to make an appointment, and to get onto their books, and to get onto their schedule, and all that. You've got a whole year or 2 or 3 to prepare for that. So that's really valuable. So there was only one patient in this group who had genetic testing who regretted it. Some patients regret it, but most don't. Most are happy that they've had whatever the result. Screening. This is a real problem because we'd love to do MRI scans on everybody. Unfortunately, but we can't. The health service can't afford MRI scans on everybody. And the machines, it's not just money, it's also machine time that's needed for people with brain tumors and other things. So my approach was to do genetic testing and restrict the screening to high-risk patients. So if somebody had a small Dice-Me 3 melanoma with practically a 0% chance of getting metastasis, they didn't have any screening at all. And like that, we were able to do MRIs on all the high-risk patients. And hopefully, we got the best of both worlds in that sense. But, and then there's a debate as to MRI versus ultrasound. The oncologists I've worked with preferred MRI for the reasons we heard earlier on. But there are ocular oncologists, very esteemed ocular oncologists, who feel that with the right patients, ultrasound is as good as MRI. It all depends from place to place. One thing I found in the States was that patients were getting an awful lot of CTs in some centers. And whether they had a good genetic result or a bad genetic result, they were getting scans every 3 months. So it's bad if you don't do enough scans, and it's bad if you do too many scans. It's a very delicate situation. And have I covered? Yeah. And then the other thing is that it's got to be the correct scans. We're still getting patients who are getting blood tests. By the time a blood test is abnormal, the liver is full of tumor. Chest X-ray, it's very rare to have a positive chest X-ray in the absence of a positive liver scan. So there are general oncologists who know very little about uveal melanoma. I'm not criticizing them because it's difficult for everybody to know everything about everything. But it's much safer, much better if the screening is done by an oncologist who has special expertise in uveal melanoma. So these are lessons we're learning from, well, lots of it's intuitive. Information. Some patients, when they ask questions, we're just told to Google. That's bad practice. It's one of the problems that is universal, a very common problem with regards to information. Patients not getting enough information. Or false hopes. One of the problems is, that's a feeling that I have, I don't have any data. It's okay for me to speak about bad outcomes and things like that because it's my job and I'm used to it and I feel comfortable and I feel privileged to be speaking to a patient about such an important thing at such a critical moment in their life, in your life. But for ophthalmologists who encounter melanoma very, very rarely, it's really painful for them. It's even painful for them to discuss removal of the eye. They can't bring themselves to do that. And a lot of people become ophthalmologists because they don't want to deal with life and death issues. They don't want to deal with vision, quality of life, cataract. So when they come to speak about metastasis, it's really painful for them. So you might think that they're being cold and careless, but in actual fact, deep down, they're probably very upset. But they're struggling not to show it to you because, doctors aren't supposed to be emotional, at least not in front of patients. So it's like a pilot of a plane. Would you like to be on a plane and there's one engine's not working and the pilot gets emotional? No, you don't. You want someone who's cold-blooded, who makes the right decision. But we can do that because we're trained to do it. But general ophthalmologists don't have the thick skin that takes time to develop. So you need to understand that, I think. They need to understand you, and they need to understand them. So patients would want to know more about the impact of the disease on life and family. That's submitted. Finance. In the United States, for instance, the ophthalmologist orders an MRI, and then the patients have to pay for it. When I got my slip disc, I wanted an MRI in San Francisco. I had real pain. And I was told that, there's a long waiting list for the MRI, believe it or not. So I said, okay, I pay for it myself. How much is it? $12,000. What? I'll wait until I can get my MRI done. So patients pay, their families really suffer because they have to pay enormous expenses for the care they've received. Here in Britain and in other countries in Europe, we're well off, but we don't know it. Communication. I said that about dying, about bad news, brushed under the carpet because it's easier to do that. A lot is forgotten. That's why I give audio recordings to patients, because I'm more worried about what they forget than what they remember. Whereas other doctors, are worried that it's going to be used against them in a court of law. But I think it's much more worrying if patients forget what they've been told. Compassion, really important and it's a problem. I'm running out of time. Emotional support, problems there. Psychological support, we've heard a fantastic talk a few minutes ago. So in Liverpool, just like Sheffield, we had a lot of psychological support. When I arrived in San Francisco, I heard about patients who were told, not just there, but other places. In San Francisco, they had a great department, ocular oncology service, but the oncologist moved to a very prestigious hospital elsewhere, and a very prestigious post as a dean elsewhere. And all of a sudden, there was no ocular oncologist. And the trainee had to look after the patients. And the hospital did their very, very best to get a replacement very quickly. But it took a bit of time, and also San Francisco is a very expensive city for young families to move to with children and so on. So within a short time, the service sort of disintegrated to some extent, despite fantastic endeavors by the university. I mean, that's why they got me there, otherwise they'd have got someone local. I was a last resort, I expect. But I saw patients who had problems because they were not given any psychological support. They were just told the diagnosis, and that was it. And luckily, just like in Liverpool and Sheffield, I was able to find a psychologist who was able to provide the support. So it is possible. So, for instance, I'm hearing a lot of negative feedback about Moorfields. I work at Moorfields. I've been working there for 2 days. My first day was Wednesday, and I'm already absent. But the ophthalmologists there are good people. They're caring people, but for various reasons, they're having a hard time, and it's difficult for them. I was lucky to be in the right place at the right time, but yes, they know that. They know that.
One or two of them should be frightened.
Well, give it some time. We'll see what can be done. But I'm sure that they want to improve things if they can. If the managers are trying. There are constraints that I didn't imagine they are suffering a lot, not as much as patients, but just as the patients are suffering one way, they are suffering when they're trying hard another way. I'm telling you, they are. From what I've seen. So with regards to improving things, I concocted a patient's Bill of Rights, what you should expect when you go to an optometrist, when your successors go to an optometrist for screening, when you're given bad news, when you're examined, when you're all these things. So I've got this, and this has been published now in this journal, and hopefully it will help to improve standards, not just in the States, but over here and everywhere. So these things are very important: empathy, kindness, compassion, understanding, communication. But it works both ways. We are trying to understand you, but it would help if you were to try to understand your doctors and the constraints they are working under. And if you're not happy with something or something, if you ask, hopefully you get the answers that you want, you get the support that you need, and so on. So I think that's an important message, that everything works both ways. So I'm sorry if your expectations have not been met, but hopefully things will improve and are improving. So I'd like to acknowledge my colleagues in Liverpool and in San Francisco. Thank you for your attention.